Which anticoagulants can be used safely and effectively treat VTE in patients and obesity? In this episode of Critical Conversations on Venous Thromboembolism, a MasterClass series on DVT and PE, Drs. Cohen and Dottlesweg discuss VTE management in patients with obesity and share evidence-based recommendations for optimizing the use of anticoagulants in this prevalent patient population. Access the full series and complete the post-test for credit at peerview.com/HBR860.
Thanks for joining us for episode 7. How should VTE be managed in patients with obesity? Well, obesity, as we know, is a modern-day epidemic. It's increasingly common. It's not just in young people, it's in middle-aged people and even elderly patients now. And it brings up the risk of VTE long-term. So let's have a look at a patient case and discuss some of the real-world evidence in patients with obesity. This is Trina. She's 46. She's 112 kilograms. Her BMI is 35, so she's obese. Got a high creatinine clearance, probably related to her weight. And she's been discharged on warfarin and referred to a hematologist. Initially, she was treated with low molecular weight heparin, but she wants to be on a DOAC. And the hospitalist recalls the ISTH guidance from the past that recommend checking DOAC levels. And this is expensive monitoring, and Trina's insurance plan may not cover it. What do we do here? Well, first thing is to think where Trina fits in the spectrum. And Trina is really class 2 or moderate obesity. The initial stage of obesity is a BMI from 30 to 35, but we see all these classes, and we see even extreme obesity with BMIs over 60. So which anticoagulants are safest to use in patients with obesity? Steve, we've got a bit of information on this now. Some we've got some data, some we haven't. Tell us what you think.
Well, first, I'm really impressed that the hospitalist knew about the ISTH recommendations. I mean, that's really kudos to that individual. But we know it goes back to 2016 when the International Society of Thrombosis and Hemostasis from the Scientific Steering Committee really did a great job in putting forth some recommendations. But at that point, it was really BMI up to 40 and a weight up to 120 kilograms. So this patient would fall within that class, but unfortunately, many people looked at that as a line in the sand and said if they went even anything above a BMI of 40 or 120 kilograms, they would, all bets were off, and we would look for peak and troughs. Not that anybody knew what to do with them, but they would look for peak and troughs at those levels, and then they would not prescribe a DOAC. Things have changed. Things have changed that have really been evolving, and these days, just to answer the question, it would be apixaban over rivaroxaban for this weight class of individual, but there's been a lot of additional information, because what it did do, if nothing else, it set the stage for people to do further research about the what if they were more just obese or morbid obese or super morbid obese, as you were showing. So I think that's where you've done some great work there.
Well, it's interesting that there's been an enormous amount of research, as you said, since that recommendation came out. So that was one of the benefits. And we've done a number of studies where we looked at DOACs and obesity, and we looked at 43,000 patients in the United States with obesity. And we looked at those who are obese and those who were severely obese with BMIs over 40. And what we saw in this is when we compared the DOAC apixaban with warfarin for both safety and effectiveness, the point estimates always favoured the DOAC apixaban. So, many of these patients and many of my patients are up around 200 kilograms, and we still manage them with DOACs at this stage. But that was an important bit of real-world evidence, I think, that we're able to publish. But should we adjust the DOACs? I'm not sure we should. I don't. I tend to use the higher dose if there's a reason, but I don't tend to adjust down if they're obese, because there is a little bit of drop off of the exposure. And can we do this without monitoring? I think we can, but I want to get your thoughts too, Steve.
No, thanks for that, and thanks for sharing your great work there. And we use the standard dose, the higher dose, and we utilize excellent, and we utilize it without any adjustment. And we typically will have that maintain that dose, and we do not monitor. We do not monitor with anti-10A in general, nor do we monitor, even though we have availability to get the moiety specific anti-10A. We don't find it necessary. The literature has not shown that, and particularly we reference Ash and Dr. Suker at University of Pennsylvania has been really excellent in that regard, guiding us.
Yeah, we're the same. We started measuring because the ISTH said to. What we found was that the peaks and troughs in VTE were pretty much in the right range. I mean, the peaks for rivaroxaban were a bit low. They were significantly low in some patients, but all of them were within the therapeutic range of over 100 nanograms per mil. So we just don't bother. All our peaks were within the range. We don't bother with measuring those doses. And you did refer to the updated guidance, and tell us what the guidance says now, Steve, with respect to the 2021 ISTH.
Right, so basically it starts by just reaffirming what the 2016 guidelines said as far as using standard doses of apixaban and rivaroxaban as being acceptable. But now they moved forward and said they took off the weight capping. So there's no longer a weight capping of the 40 BMI or 140 of the kilograms and 120 actually. And so they move forward and said that's appropriate for treatment. They do go further and say whether you use for prevention or treatment the bigatran, edoxaban, betrixaban, that data is not sufficient. It's not convincing. The PK/PD data does not support using one of those agents. And nor should you look at anti-10As, exactly what we were sharing a few moments ago. So that would be where we would want people to focus on. And then we have changed a few parameters for Trina. She was obese, but now she's extremely obese with 160 kilograms with a BMI of 62 and has chronic kidney disease, creatinine clearance of 80. Acute treatment was initiated with weight-based low molecular heparin. Which anticoagulant would I select now? I would follow the guidelines. And ISTH gives us some pretty clear support to using apixaban or rivaroxaban in that regard. And I would stay with the higher dose. That would be my initial suggestion.
Same here. And I wouldn't monitor, like we said, but if she had bariatric surgery, I think during the period she had bariatric surgery, I'd probably switch her over to low molecular weight heparin to cover her because of the absorption problems. But then back on the standard dose of either apixaban or rivaroxaban.
Yeah, our approach for that would be is similar, is that if she's had bariatric surgery, we don't consider the DOAC until at least a month after the bariatric procedure. And at that point is when we would consider resuming, but we would check a DOAC level and a trough level to make sure that she's having some degree of absorption. So that really would wrap up our recommendations, Dr. Cohn and I's recommendations for anticoagulant therapy in patients with obesity, common occurrence. And in our next and last episode, the 8th, we'll discuss special considerations for anticoagulation therapy in patients with cancer.
Yeah, lots of new information, Steve.
Thank you for listening to this podcast episode. Download the slides and practice aids for this episode and others at peerreview.com/HBR860. Be sure to listen to all 8 episodes in this MasterClass series and complete the post-test for instant credit at peerreview.com/HBR860. This activity is supported by an educational grant from the Bristol Myers Squibb and Pfizer Alliance.